everyone, and welcome to Anesthesia DDS, where we'll be talking about all things anesthesia as they relate to dentistry. My name is Dr. Kenneth Lee. I'm a dentist anesthesiologist that practices in Los Angeles, California. And for our very first podcast, we welcome all our viewers. I'd like to introduce Dr. Andrea Fonner. Andrea is an amazing dentist anesthesiologist that works as a mobile provider in Bellevue, Washington, in the Seattle area. I've known Andrea for many, many years, and I've just watched her become so important in terms of the anesthesia community. She is past president of the American Dental Board of Anesthesiology and has been a board examiner and primary contributor for many, many years. She serves in so many positions, currently with the American Dental Society of Anesthesiology. Nationally, she is on the board of directors. Locally, she is the president of the Washington component. She is president and co-founder of Anesthesiology for Dentistry. Her passion is teaching dentists around the world about ways to improve patient safety. That we have in common. She was the co-creator of the ADSA 10 Minutes to Save a Life emergency app and manual, which is the only cognitive aid text that exists for dentistry and is used all around the world. She is co-director of the ADSA High Fidelity Human Simulation course and is co-director of the Oregon Academy of General Dentistry Parental Moderate Sedation course. This is a very brief bio because I looked at her CV and it's 9 pages long. So it's a very brief bio. The best part of her day is spending time with her husband, Matt, and 2 beautiful identical twin girls, Lauren and Charlotte. Andrea, welcome to the podcast.
Thank you so much for having me.
So in today's first episode, I wanted to be clear with how in dentistry we have different levels of sedation. We have different education commitments that we need to have to achieve those levels. And I know that the ADA, American Dental Association, has put together some guidelines. Some of these guidelines are a bit old. I think their latest update has been at least 5 or 6 years. And I know that you're working on a committee to work on that. Is that correct?
That is correct. I serve on the ADA Anesthesiology Committee.
So that must just take a lot of time. What types of things are you talking about? What types of things are you looking at?
So one of the primary purposes of that committee is to look at the teaching guidelines and the use guidelines for dentists. And so we are doing that. We are in the process of doing that. That did get delayed by a few years for various reasons, but we currently have a meeting set for May of this year to look at both of those guidelines as a community and really come to a consensus as to what needs to change about those.
So this is for all levels of sedation that you're looking at?
For all levels of sedation, yeah.
And so what are the current guidelines? What year were the current guidelines adapted? Do you know?
I want to say 2017 was the most recent iteration.
Right. So that's what I have too. The revisions were in 2017. Initial guidelines were in 2012.
Yeah.
So good luck with that work. That's very important work. What brought you to that calling? Why did you seek that? Were you unsatisfied with the current guidelines?
No. So the ADA has a policy to look at these guidelines every 5 years. So they take their anesthesiology committee, which is constantly changing. I am the representative for the American Dental Society of Anesthesiology, and we serve 4-year terms. So my term is actually going to be up this year in 2025, and so there will be a new representative. So they rotate people through, but they really CDAL really relies on that committee to be the body of experts when they're looking at revising the guidelines.
Great. Thank you. So in 2018, the ASA had proposed some guidelines. I think it was a joint collaboration between ASA, American Dental Society of American Dental Association, the ASDA. Have those guidelines been put into action, or are they just still proposed guidelines that you're currently working on with the ADA?
So my experience with the ADA does not involve those particular guidelines that were published.
Okay, great. So first topic we want to talk about is minimal sedation. And in terms of reviewing the levels of sedation. I know, Andrea, that you're very passionate about different levels of sedation and how they interact with each other. So can you talk about that, first of all, with anesthesia, minimal, moderate, and general anesthesia, and how they kind of all blend together?
Yes, I think this concept of sedation being a continuum is something that is not discussed enough, and I think that this concept might not be taught in a lot of the courses to the fullest extent that it should be. So when we're looking at sedation, we're looking primarily at responsiveness, airway, spontaneous ventilation, and cardiovascular function. And so as you go through this continuum within sedation, with minimal sedation, usually most of us think of that as like an oral sedative, right? And so it provides anxiolysis, but typically the responsiveness is still normal. When you ask them to open their mouth, they will. When you go into the moderate level of sedation, that's when you may have to raise your voice a bit, or maybe tap them on the shoulder or the arm to get them to respond to whatever command that you are desiring, right? So if you say, Bob, I need you to open your mouth, maybe he's not going to do it right away, but the second you raise your voice, tap his arm, Bob, I need you to open your mouth, then they do it. This level of sedation is very, 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 very safe. And the reason for that is because not only are they responsive to your verbal commands, their airway is not affected in any way. Their ventilation is not affected in any way, and their cardiovascular function is usually maintained as well. So that's why this level of sedation it's a great service for dentists to be able to provide to their patients, and it's very, very safe. Now, once you cross this line into this deeper level of sedation, that's when you can run into some issues. And the reason for that is because their level of responsiveness is going to be diminished. So you may have to stimulate them with some sort of painful stimulus. Sometimes we'll squeeze their shoulder or something like that, right, to get them to respond. And you may have to intervene with their airway. So by definition, if the patient starts to obstruct to the point where you have to do like a head tilt chin lift, then that is a deep level of sedation. And what isn't being taught in a lot of these courses is when you get into that deeper level of sedation and you have to intervene with the airway, the most important thing to do is to recognize that you're in a deeper level of sedation, which is outside of the scope of the current permit that you have, and that you need to stop the procedure and then get them back into that moderate level so that you stay really safe with patients. In this level of sedation, spontaneous ventilation may be inadequate and cardiovascular function is usually maintained. And then the final step in this continuum, of course, is general anesthesia. And this is when there's no response, even with a painful stimulus.
And so, Andrea, you talked about a line when you cross this line. It's a pretty fuzzy line because when you provide more stimulation, patients can become more aroused and more awake and respond to verbal commands. But if the stimulation is taken away, they can also drop into that deeper level of sedation. Same with administering medications. You may overshoot moderate sedation and go into deeper sedation, and more stimulation again brings them up into a moderate level. So that line, and I want to be clear, when you talk about the continuum, it's a very fuzzy line that can go deeper and lighter depending upon medications delivered and stimulation. Is that correct?
That is correct, yes.
So let's talk about the first phase of that. And there are some things that you touched upon in your description of the continuum that we'll hit upon later. One of them is rescue, so we'll talk about that as well. But let's talk about that first level of sedation that we're talking about, which would be minimal sedation. In this type of sedation, drug dosages should not exceed the maximum recommended dose for unmonitored home use. And 2 or more enteral drugs would be considered moderate sedation. So with ADA guidelines, 16 hours of continuing education is recommended, which really isn't very much time. Let's talk about minimal sedation and your experience with sometimes how that gets abused a little bit and produces a deeper level of sedation. Do you have any stories or any side notes about experiences with that?
I think that can occur more frequently with the stacked dosing concepts, right, that some people teach.
So talk to us about the stacked dosing concept, if some of us aren't aware of it. What do you mean by that?
So typically when you're using a medication for oral sedation, you're going to give one dose of that medication. Primary reason for that is because of this idea of titration. You can't titrate an oral medication, right? And if you are intending to practice within a certain part of this chart, right, the minimal level of sedation, you're not intending to go into that moderate level, then there's no way for you to know if that full effect of that first dose is actually working the way it should be or not, right? So you shouldn't be giving an additional dose, a stacked dose of that medication, because there's no way for you to know when that is in full effect, when that medication is taken full effect.
So basically repeated doses before the initial dose has time to take effect.
Exactly, yes.
So in a case like that, it's pretty easy to drop into a deeper level of sedation, even sometimes general anesthesia. Is that correct?
In theory, that's possible, yeah.
Okay. So in terms of the minimal sedation where we use just the maximum recommended dose, that's a very safe technique, even if we use it with nitrous oxide.
Yeah, and for most patients, I think that making sure that you are picking the correct patient, that is a key aspect of the safety, the level of safety.
So talk to me about that. You brought that up. So what types of patients would, let's start off with the negative. What sorts of patients wouldn't be good people to use that for example? Obese patients, maybe?
Yes, or morbidly obese patients, anyone that has a difficult airway for whatever reason. Again, because you can't titrate an oral medication, you have no idea what the patient's response is going to be for that particular medication. So you might find yourself in a much deeper level of sedation that was initially intended. So patient selection is really the key to ensuring patient safety.
And when you talk about if they look like they have a bad airway, so some of the things that I look at, when I was in dental school, I looked at everybody's teeth because that's what I was learning. And then when I went to my anesthesia residency, I started looking at, facial features. I started looking at their veins, their hands. I looked at people and said, man, I don't want to take care of you under anesthesia. So those are some of the things that possibly you've been mentioning with when someone has a bad airway. So there are some components to that. One of the components is, one thing to understand about all these components is that not one single thing directly points to a bad airway, but if you have a lot of things that point to a bad airway, most likely they're going to have a bad airway. For me, the most important thing is class 2 malocclusion, or a mandible that is retrognathic. The reason for that is as a patient starts to become sedated, their jaw does not advance forward, it advanced backwards. And with sleep apnea appliances, what do we want? We want to pull their jaw into a class 3. So when they're retrognathic, that typically will lead to a more difficult airway, especially if we're now trying to do dentistry in the mouth. One of the things as dentists and as anesthesia providers, our surgery is in the mouth. So we are sharing the airway. So that's even another more important reason why we need to look at someone's physical features. Andrea, what are some of the things that you look at when you see someone and evaluate your patients that would help indicate, hey, this person is a good airway versus a bad airway?
So history is important, right? You're going to be asking all of your patients if they snore at night. You're going to be asking them about any history of sleep apnea, because those are going to certainly be indications that they could potentially have a more difficult airway. It also is a good indication that when they become sedated and everything becomes relaxed, that perhaps their airway becomes compromised in one way or another. Also, you're going to ask about any history with sedation and general anesthesia. Have you ever had any problems with sedation? Have you ever had any problems with general anesthesia? If the answer to either of those questions is yes, you want to fully investigate that. And then when I'm doing an airway exam and when I'm teaching sedation courses for dentists, what I teach them is to be able to look at the facial structure where you would put a mask. So if you did have to ventilate someone, what are things that could impede your ability to get a good seal on that mask? So things like what you're talking about, a retrognathic mandible, right?
Right.
High palate, like a narrow palate that's high vaulted, right? Any teeth that are protrusive in any way that could impede your ability to do that. Facial hair is something that
That's a big one. That's a big one.
We always take that into consideration as well, because that might impede your ability to get a good seal on that mask. So that's what I teach people primarily, is to imagine having to ventilate them and imagine how things could impede with that. Also, Malampati classification we teach, which is when you open your mouth really wide and you look to see what structures are visible. So if you only see a hard palate, then that's an indication that they would have a more difficult airway. Whereas if you're able to see the tonsillar pillars, the uvula, the posterior pharynx, then that would be an indication that their airway would be a little more normal.
And so one thing that when dentists are doing their oral exam, like when I do an oral exam, I also look at their mouth. Do they have a small mouth? They have a small mouth, large tongue. There's not a lot of room in there. So that's going to be something where air is also not going to be able to pass through there very easily. Those are things that you look at also in terms of, hey, doing a sedation on this person and doing dentistry might take you a lot longer. So those are just things to consider when you're throwing anesthesia into the mix of treatment that you have to look at. So lots of things that point to a bad airway that we just discussed. Not one single thing may be 100% you have a bad airway versus a good airway. But when you start stacking those things together, one over another, then most likely you're going to have a bad airway. And minimal sedation. Who cares if I have a bad airway because they're minimally sedated? But again, that continuum of anesthesia that Dr. Fonner talked about is patients can dip into a deeper level and airway intervention might be necessary. So don't always assume that you won't need to do that. So thank you for that, Andrea. And next, let's talk about moderate sedation. So this is near and dear to your heart, as you've taught probably thousands at this point, at least hundreds of dentists doing sedation. My experience with moderate sedation training is currently with the periodontal graduate residents at USC. I don't do general dentists in a moderate sedation course anymore, but I know you do that. So tell us about your experience with that and what you're trying to teach, and we'll go over some education guidelines as well. So what does moderate sedation mean then? What are we trying to achieve?
Well, what you're trying to achieve is you want the patient to be relaxed and comfortable, but conscious throughout the procedure. So understanding what moderate sedation is and what moderate sedation is not is of primary importance, right? I think that one of the number one reasons for a failed sedation is not describing appropriately to your patient what moderate sedation is.
Agreed.
Right? Your patient should expect to be awake. They should expect to be comfortable and relaxed, but they should expect to be awake. So if they're coming in thinking that they're going to be quote unquote asleep, then you can imagine how disappointed they might be when they're not, right? And they might tell you that over and over and over. I'm not asleep. I'm not asleep. I'm supposed to be asleep right now, and they'll have zero recollection of it, right? But it will be, it will hurt your ability to do the dentistry.
So one of the things that I talked about, so I'm most of my patients are under general anesthesia, but there are some that we still do moderate sedation for a variety of reasons. Yep. One of the things that I talk to them about is, Mrs. Jones, you're going to be comfortable with the medications that I'm giving you. We're not going to put you to sleep. You may be so relaxed that your eyes may rest and you might fall asleep, but I'll be able to wake you up just by talking with you. So with that expectation, patients already know that, hey, I'm not going to be asleep, just like you said. And that expectation is huge. I practiced in a very rural community in Northern California for a few years where patients were pretty unhealthy, diabetic, hypertension, hyperlipidemia, all those things, tended to be obese. And I worked in an office that, wanted those patients to sleep. And there were a lot of patients that I looked in the eye and said, we're not doing general anesthesia, because of different medical reasons. I'm going to do a more conscious sedation where, again, you'll be comfortable. We're still going to use local anesthetic. Most likely you won't remember anything, and most likely you'll be so relaxed that you may fall asleep. But again, I'll be able to wake you up right away by tapping on your shoulder. And I think that's really, really important when we talk about moderate sedation. And so what about cardiovascular and respiratory function? Are those affected much in moderate sedation?
Not typically, no.
Okay. So very mildly affected. Airway intervention is not necessary.
Exactly. That is the primary idea behind this, because once you have to intervene with an airway, so let's say your patient does fall asleep, quote unquote, they're so relaxed that they fall asleep and they start to snore. By definition, that is deep sedation. So you have already crossed that line and you're in a deeper level of sedation. You might be able to just do a very simple head tilt chin lift to open up their airway again, and it may not compromise their oxygen saturation levels or anything, but you have to recognize that that's a deeper level of sedation than what is intended. So the second you have to intervene, that's deep sedation, you should be stopping the procedure, getting them back into that moderate level, and then proceeding from there.
So not necessarily reversing a patient, we've heard that, but just waiting until your patient becomes a little bit more awake so that responsive to verbal commands. And I've had this question asked of me a lot. So I'm in, or mentioned to me a lot, not necessarily asked of me, but I'll ask a doctor how they do their moderate sedation and how they're evaluating whether the patient is still in moderate sedation. And the response will be, well, when I inject them, they move their head, or when I stimulate them, they move their head. And that's a response, but is that typical of a moderate sedation, or would that be considered deep sedation if all they're responding to is just a painful stimulus?
Yeah, if that's all they're responding to, that would be deep level of sedation.
So the main thing that we're looking for is no airway compromise, correct?
Correct.
And responsive to verbal or light tactile stimulation.
Right. You may have to raise your voice a little bit or tap them on the shoulder to get them to do what you need them to do. But yes, that is a moderate level of sedation.
And what sort of minimum educational requirements would we need to do to get a moderate sedation permit? So
a lot of states will differentiate a permit for enteral moderate sedation and parenteral moderate sedation. So enteral would be the oral medications. And then the parenteral would be, most of the time we're talking about intravenous sedation. And so if you're going to get a permit for intravenous sedation, you need 60 hours of didactic, and you need to treat at least 20 patients for most states in the United States.
So are requirements state by state then? Yes.
Requirements are state by state. Yes.
And the 60 hours, that's primarily ADA, American Dental Association guidelines. And that's what most states use?
Most states use the 60 hours in 20 cases. Yes.
Okay. So the courses that I've been involved with, 60 hours is not much. 60 hours is not much to go over all the materials that we need to do. Yep. And certainly to do the 20 practical cases, those really should not be included in the 60 hours. So no. How many hours in the courses that you've been involved with, approximately how many hours of didactic do you give?
Oh, we absolutely give 60 hours minimally. In the end, when they complete the course, they do the didactic component and the clinical portion. They're getting a certificate that says that they have well over 100 CE hours from the course.
Which includes the practical cases that they've done in the clinic,
Yes.
and the didactic, the 60 plus hours of didactic that they have
Yes.
in the didactic portion. And in terms of the clinical cases, what are they doing? Are they doing sedation? Are they doing dentistry? Are two people sharing the cases? What's the best way? If I'm looking for a sedation course, an IV parenteral moderate sedation course, what things would you advise me about?
That's a great question. I love that question. I have a couple of thoughts on this. One, I think the primary thing you should be looking at is the faculty. Who is teaching you how to do sedation?
Huh,
So you want to look at their level of training, what their background is, what their experiences are. Are they clinicians? Are they academic types? You want probably a mix of both, right? So that you're getting a broad range of knowledge and skill. I think that it's important that the course director is a dentist. I think there's a lot of nuances with sedation in a dental office. One of the things that you talked about previously was we're sharing the airway, right?
Absolutely.
That's a huge thing. And so I think that you want to be learning this from someone who is a dentist, somebody that has knowledge about how you do sedation in dental office and knowledge about dental procedures, how long they're going to take, how invasive they're going to be, things like that. I'll give you a hint. If you Google the names of all of the instructors in whatever course you're looking at, you're going to get a lot of really good information. So I would start with that.
Okay.
Secondly, I would look at my state guidelines. So there are certain states that will include or exclude certain courses. So you want to be sure that the course that you're looking at is going to be recognized in your state. And then the third thing you want to look at is how it's run. So the didactic portion, I think it's really important that it's an in-person event. Again, this information in the 60 hours is crucial to keeping your patients safe. And it's a lot of information that goes beyond the typical curriculum in a dental school setting. And so it's very, very, very important information. And you don't want to be phoning this in by kind of halfway listening on a Zoom type of meeting, right? So I think that the in-person aspect is really important. As far as the clinical cases, I also think it's really important that you are starting an IV on all 20 cases, and you're the one titrating the medication for all 20 cases, and you're the one doing the dentistry on all 20 of those cases. And the reason why I think that that's a really important aspect of this is because that's how you're going to bring this into your office, right? So why wouldn't you learn it right the first time and learn how to do everything at once? Because that can be overwhelming. If the first time you're doing that is in your own office without any instructors there, without anybody else being there, then I think that that curve is going to be a lot steeper than it needs to be, right? So I think that looking at that, and then ideally, you also have some sort of simulation type experience in the course so that you can practice all these airway management skills, because we're going to go over how to open an airway. We're going to go over how to use an LMA, how to use an OPA, all of these additional devices. But if you just learn it from me telling you that, and you don't learn it from you actually placing it, you don't want your first time to be on a patient that's having an airway problem, right?
Right.
So keeping your skills up, first of all, learning it, and then secondly, keeping your skills up by attending a simulation course on a regular basis, I think is really important. And then lastly, the location, the cost of the course, all of those things, the ease of travel, those things are kind of minor once you've evaluated those other aspects of the course.
Now, when I've taught moderate sedation courses, I've been part of the clinical, I've been part of the didactic. That live in-person thing is crucial, because there's a lot of conversations that you have even during the didactic portions. A question comes up and it gets shared amongst all those in attendance, and we can expand upon that and base things on experience. So that's really important to get answers to questions, to clarify things. As educators, we think we're providing the information clearly. Sometimes we don't do that, or sometimes, as one of my residents told me, that's not the way that I think. So you need to give it to me in a different view. So those things are important. Yeah. And in the clinical sessions, back in the day when we taught courses together at USC, you're doing the 20 cases, you're starting the IV, you're doing the dentistry, but you're also learning from the other cases that are there. So that shouldn't be your primary way of learning how to do sedation, but you're certainly learning from all those other experiences. When I take a course, because I still do dentistry, and when I take an implant course, and I remember the first implant courses that were hands-on, well, I didn't want to share the cadaver with someone else because I wanted to do all those things. Yes, I learn from someone else when they're doing it, but I want to be able to place those implants, in a pig jaw, whatever the case might be, learning how to suture. I want to do that on my own. So I think with sedation and anesthesia, that's even more crucial as we take this from the classroom and from the course that we're learning and implementing that on Monday morning. There's a lot involved with that. So the more information and knowledge that you can gather, I think is best. And I agree with Andrea that the best way is to do those cases on your own with obviously faculty there, but to do the dentistry, to start the IVs, because when you go back into practice, you're it. You're the doctor. And there's no one else there that's going to bail you out. So we should try to learn as much as possible during those courses. So enough with that, but let's talk about some monitoring, blood pressure, heart rate monitoring, pulse oximetry. What are your thoughts on capnography?
So most states at this point agree that capnography is necessary for moderate sedation. I'll leave my personal opinion out of it because it's irrelevant at this point. The ADA, so in 2015, I believe, well, what started this was back in 2012, the ASA incorporated the use of capnography for any moderate sedation that was occurring anywhere else in the hospital. For that, it wasn't inefficient in any way as far as costs, because all of the monitors had the capabilities. It wasn't that big of a deal to implement this, so everybody was on board with it. In 2014, the oral surgery group implemented this into their guidelines because of the American Society of Anesthesiologists. And then in 2015, it was brought before the House of Delegates to change the ADA guidelines for dentists that practice moderate sedation. It failed the first time, but then it passed the following year, I believe. So it's been kind of a journey, but at this point, almost every state requires it. And you're going to buy a monitor that has capnography now, you're going to have to. So the cost aspect is kind of moot at this point. But my opinion on it is that,
yes, tell us your opinion, Andrea. We want to hear your opinion.
Well, your patients are conscious, right? And so is it really necessary? I'm not sure. But I use it all the time because I'm primarily doing general anesthesia as well, but I use it for my moderate sedation cases as well. The issue with it is sometimes you're using a gas sampling line that is on a nasal cannula, for example. So there's a number of ways, and we can discuss the various ways that you can monitor end-tidal CO2 in a dental office. So there's endless ways to do that. But a lot of people will use a nasal cannula, and then they'll plug that directly into their monitor. And if the patient's not breathing through their nose, it's going to flatline, right? It's going to say that they don't have any end tidal. But you're going to take one look at your patient who's responding to you and is awake, right? And you're going to know that that's not a problem. Right?
So capnography is not accurate with moderate sedation, because sometimes maybe the patients are talking and you're not getting a CO2 reading. Is that what I'm hearing you say?
I wouldn't say that it's not accurate. The actual number is probably not very accurate because it's an open system as opposed to taking a direct sample from the lungs, right? So when we intubate our patients and we're taking that direct sample, then that reading that's on there is accurate. So that number that you're getting isn't accurate. But the waveform, just the fact that you have a waveform is indicating that that patient is ventilating. But like you said, there are some things that can happen during a procedure where maybe that waveform isn't there, and you just need to troubleshoot that very quickly. But the the most important thing is to look down at your patient and see that they're conscious,
Absolutely.
responsive, and then that's it. And then you move on.
Absolutely. So with moderate sedation, we talked a little bit about that today, and certainly there's drugs in our future podcasts. We'll be talking about drugs, but drugs really must carry a wide margin of safety, correct? And where we're really not going to be likely to have unconsciousness. So certainly there should be certain drugs that are more conducive to moderate, and certain drugs that are not.
Yeah, it's important to know that any drug that we use can induce general anesthesia. Any drug, it just depends on how much you're giving, right?
Right.
But the types of drugs that we use in dentistry for moderate sedation are very safe. They have a wide margin of safety, like what you're talking about. And so the beauty of IV sedation is that you can titrate the medication. So you're giving them exactly what they need, nothing more, nothing less. You can give them the exact amount that they need. And you can recognize right away if that's too much. But the beauty of these medications is that even when you do give too much, which is going to happen, right? And that's why being able to recognize a deeper level of sedation is crucial. These drugs have such a short duration of action that they go back into moderate typically within a few minutes.
And so with moderate, we can induce, like you mentioned, general anesthesia with any drug. We can induce general anesthesia with any technique, oral sedation, IV sedation. We can induce that, and which goes to introduce us to our next topic, which is like rescue. So the ADA guideline specifically mentions that if I'm a moderate provider, I have to be able to rescue a patient should they become into an unintended level of deeper sedation. So that rescue could be something as simple as head tilt, could be something as simple as monitoring the patient until they go back into a deeper level, but can also involve more advanced airway support should rescue be necessary with that, or reversal. So with these drugs, with their wide margin of safety, it's unlikely, but it can obviously become a deeper level of sedation. That's just part of the ADA guidelines. Again, rescuing a patient, titration, which you mentioned, small incremental doses over time, not giving every patient 5 milligrams of this, 50 milligrams of that, titrated over time.
Yes, absolutely. And it's impossible to predict how an individual patient will respond.
Absolutely.
So,
from day to day.
From day to day.
From day to day.
Off the table.
Right.
It's impossible. So.
Yeah, we have patients that we do general anesthesia on an annual basis. A lot of them are special needs. And one day they come in and they need a lot of medications, and the next year they don't need nearly as much. Some days they're cooperative, some days they're not. So it is literally day to day with patients. You don't know how they're going to respond. You don't know what's on their mind. You don't know what other things that they've taken in terms of medications, or how well they rested that night. So definitely titration is very, very important. And then ultimately rescuing with drugs that have, for lack of a better term, an antidote or a reversal agent. What types of drugs would those be specifically?
So with the benzodiazepines, most people are using midazolam to do moderate sedation in dentistry. And so the reversal agent for that would be flumazenil. That does have a range of dosing. So it's typically 0.2 to 0.5 milligrams that you would administer. But in my opinion, these drugs should only be administered for a patient that is deteriorating and you are unable to ventilate. This should never, ever be used to hasten any sort of recovery. And the reason for this is because the clinical duration of action of the reversal agent is not as long as the clinical duration of action of the actual medication. So what can happen is they can be reversed and appear completely awake and then go home and then get sedated again. And that is a very dangerous thing that can happen. And so if you are going to use a reversal agent, again, in my opinion, it should be kind of a last resort, and you need to monitor them for at least 2 hours after administering it. That's according to the package insert. And then, of course, the reversal agent for our opioids is naloxone. Narcan is the brand. So.
Okay, so just to recap on the key elements of moderate sedation, Patient selection is important. It's huge.
Very important. Yep.
In terms of training, titration medications, and in terms of choosing the proper course that would best suit successful entry into moderate sedation. We talked about that. And some of the ADA guidelines about being able to rescue a patient from an unattended depth of sedation. And also we talked about monitoring. So great. So we're going to proceed into deep sedation or general anesthesia. And I know that in dentistry, oftentimes deep sedation and general anesthesia are used synonymously. There are, I think, a few states that provide a deep sedation permit. And Andrea, correct me if you know any different. And they're deep sedation versus true general anesthesia sometimes are differentiated. In California, they're one and the same. Do you know any states that separate that at all, or is it pretty continuous these days?
I think that it's pretty universal at this point that they're in the same category.
And in terms of training, is this something that we can learn in the CE course to learn how to do deep sedation?
No, it is not.
So the criteria that we need to do to achieve a deep sedation general anesthesia permit is a residency either in anesthesiology, dental anesthesia, or oral surgery residency. Fortunately, we dentistry does not allow us to learn deep sedation in a CE course. Anything else that you want to touch upon in terms of route of administration or education with those things?
I would just really encourage people to look into a parenteral moderate sedation course. I think that service is so beneficial in so many ways. Every single person I've ever taught has implemented this into their practice successfully and been very, very happy with the results all around. Patients are happier, staff's happier, you're happier, you're able to do more procedures in a shorter amount of time. And it's just a fantastic service to be able to offer to our patients. And it's very, very safe. If you stay in that moderate level of sedation, it's a very, very, very safe way to treat patients. I think more so than oral sedation.
Agreed.
And sometimes even more so with just local alone. So I would just really encourage people to get certified. And then you're also learning how to start an IV, which puts you in a totally different category where you're able to administer drugs intravenously, and you're just going to be a higher level dentist at that point. So
one last thing I'd like to go over, our pre-op encounter. We talked about selecting the right patients. There's obviously a classification that we have to use to select those patients, ASA, physical status classification. Let's talk a little bit about that. Let's talk about how you classify your patients, what are important things with ASA 1, 2, and 3, things like that, and what gets your radar up when you see certain things on patients' medical history. So ASA 1, healthy patient.
Yep.
No medications.
Non-smoking, minimal alcohol use, no medications, no allergies.
Boring. A boring patient.
We all can hope to be an ASA 1, but
no recreational use of substances. I think even a social drinker now is ASA 2. I mean, even if you're a social drinker, I had a patient once, I asked them if they drink any alcohol, and they said, oh yeah, I drink it socially. And so my response was, okay, like once a month, once every couple of weeks, Super Bowl party, that type of thing. And they said, no, socially every day. So we got to figure out what socially means, socially at the happy hour. But ASA 2, mild diseases, patients with diseases that are controlled, social drinking, social alcohol drinking. What other things are you looking for ASA 2?
BMI.
Okay.
Right. So we're always evaluating a patient's BMI. If they have a normal BMI, then they can still qualify as the ASA 1, along with the other things that we talked about. But anyone that is beyond that normal level, so normal level would be 25. So anything above 25 would be overweight. And so that would put you in an ASA 2 category. the drinking, well-controlled hypertension, a smoker, somebody with a drug allergy, someone who's taking medications on a regular basis to possibly treat mental health disorders, things like that. I would classify as an ASA 2.
And as we get into ASA 3, which are more serious, less controlled situations, BMI is also included in that. BMI of over 40, which we certainly don't recommend for moderate sedation or even minimal sedation. But someone with a BMI over 40 certainly is to be considered an ASA 3. Something that I do when I evaluate a patient, even if they're an ASA 2, quote unquote, by the book, right? There's different ways that we can classify patients. A blood pressure, functional reserve. I always talked about patients about being able to go up a couple flights of stairs without stopping. But sometimes I look at anatomy. We have patients with facial anomalies, or if there's something that makes them difficult to ventilate, that I would consider difficult to ventilate. Sometimes I just put like a plus, like a 2+. Sometimes just because, and even there are often a few times that I've even put them into a ASA 3 just because there's so many things that accumulate, and then if I'm not going to be able to ventilate them, that's kind of an important thing too with risk assessment. So even though we have these set ASA 1, 2s, and 3s, there is a little bit of critical thinking that we need to do when we see an individual patient to diagnose them correctly. And then further, in terms of pre-op, can you just briefly talk about what things you do in terms of pre-op evaluation for your patients undergoing anesthesia?
So you want to do a complete medical history, right? You want to review all the systems, make sure that you're getting full answers regarding their cardiovascular status, their pulmonary status, their kidney function, if they have any musculoskeletal type issues, if they have a history of nausea, either from like riding in a car or after procedures. You're looking at their social history with regard to smoking, recreational drug use, alcohol use. You're looking at their snoring. Do they snore? Do they have a sleep study that can indicate sleep apnea? Do they have a CPAP machine? So you're just going over their medical history very thoroughly. And then you're getting that history of sedation and general anesthesia that we talked about earlier. And then you're doing your physical exam. You're listening to their heart, their lungs. You're looking at their airway. You're identifying Mallampati classification. You're verifying NPO status. So it's important that they don't have anything in their stomach. It's interesting that these GLP-1 agonists right now are starting to complicate that a little bit.
Absolutely.
I'm sure we'll get to that on a different podcast.
We will get to that on a future podcast for sure.
Yeah. But making sure that they're NPO, making sure that the consent forms are all signed, those are the things that I'm taking into account before I do sedation.
And when I do a pre-op evaluation, I'm obviously looking at the medical history that the patient has filled out. That's in one hand. In the other hand, I have a pre-anesthesia evaluation form, and I can share that form. Yeah. I can share that form with any of you that are interested. I'll put it onto my website, one-to-one-anesthesia.com. But I double check, right? It's redundancy. What they fill out and what I write down when I ask them the question should be the same. How many times have you had a patient that said, you asked, are you good? Are you in good medical health? And they say yes, but they're taking 5 or 6 different medications. So I do the physical evaluation and the medical history review with 2 different forms, and kind of ask questions in 2 different ways just to be sure that I have the same answer. And then finally, when we go to the day of surgery, I have a little checklist. My checklist just happens to be OM AIDS because that's what I learned in dental school. That's what I learned in residency, where we talk about where I check and evaluate everything in the room. O being oxygen, M being monitors, M also can be machines. A, airway, is my airway available? IV bag. D drugs and suction, and for me, succinylcholine. Do you use any sort of checklist like that? Can you share your checklist?
Yes, I remember that acronym, the Ms. Maid's acronym. So I have a checklist on my anesthesia record, and so I'm checking all these boxes as I'm checking suction, for example, is one that you didn't mention there. All my airway equipment, so my laryngoscope, I check to make sure that it's working properly. I have a McGill forceps there. I have my nasal pharyngeal. I have OPAs available, and right beside me, I have all of these things within arm's length.
Correct. Right. It should
So
be.
I use it on my sedation record.
Right. And it shouldn't be your emergency kit, your LMA, your airways. It shouldn't be like, John, can you go into OR2 underneath the bags over there? Can you pull out the emergency airway kit? Those things should be right away, ready to go, right when you have them, when you have the emergency.
I encourage practitioners to have the equipment that's necessary for that particular patient out and ready to go. So for example, the correct size mask. If you needed to ventilate that person urgently, do you have the right mask for that particular patient? So you're not digging through a drawer trying to find a mask that's ready to go. You have already pre-sized an oral pharyngeal airway and you have that ready to go. I really like that idea of having a bag valve mask ready, the mask ready, the OPA ready, and reversal agents out and ready, not drawn up, but just out and ready. They have the right syringe that you would need to administer it, and you have the vials out so that nobody's running and digging for anything.
And I'll go one further. Your 10 minutes to save a life app. Make sure that you've reviewed that, and so that you have the appropriate, because on that application, you can place the weight of your patient. So it can calculate the drug dosages for emergency medication. So that's just part of your checklist.
It is. And yes, I would love to come back and talk to you more in depth about the utilities of the application, but so when you plug in the patient's weight, it will automatically calculate every single drug, any emergency drug you would need for that patient. And you can also use it for your local anesthetic, which people use on a day-to-day basis, right? So
yes, we'll definitely bring you back to talk about that, amongst other things. So anything else in closing that you want to talk about? Is there anything that you want to clarify at all?
No, I think this is great that you're doing this. I'm really excited to listen to future episodes and hopefully participate again.
The onus of this podcast is there's a lot of information out there. A lot of that information is terrific. Some of it not so great. So I just wanted to be sure that, everyone's on the same page, that we have the people that are creating the guidelines or discussing the guidelines, so that everyone's just on the same page. I want to provide good information. And Dr. Fonner, I want to thank you so much for joining me on this pilot episode. Hopefully there'll be many, many more to follow. I know we took away part of your day from the kids and your husband, but I want to thank you. Thank you very much for joining me today.
Yeah, thank you for having me. I appreciate the opportunity.
Great. And so we'll see you, everyone, for the next podcast in the future. I think we'll talk about some drugs that we use in dentistry. So until then, we'll see you at the next podcast.